So good afternoon, everyone. We have 1 or 2 minutes left to start. We'll introduce stuff to you. This is an IC on what next? Dilemmas and difficulties during cataract surgery. See, the instrumentation techniques, everything has improved, and the problems which can happen has tremendously reduced because of the technical improvement and the instrumentation. But then every surgeon, whether you're young or novice or experienced or whatever, can have problems. So when you have problems, especially in challenging situations, it is more so. So when you start doing challenging cases, then you get to problem situations. So problem situations, and then what next? So if we see experienced people handling complicated situations, we will realize this is the best way, one of the best ways to get to a very good visual outcome in such kind of cases. So along with me, I am Dr. Minu Mathan, and along with me, we have very experienced cataract surgeons. They have decades of experience behind them, including Dr. Chitra Ramamurthy from Coimbatore, Dr. Sudeep Das, who is now in Kerala now in Kottayam, and Dr. Matthew Kurian from Cochin, and Dr. Sunil Tangaraj from Vizag. So, madam, you want to go first or I'll go first? Okay.
Only in that time.
No, because we have shifted now. We have switched.
He's going to have the hall full. Change my and Monday also for my next year elections.
So, good afternoon again. So, there was a slight switch in topics. I will talk on when the lens does not crack or the nucleus does not crack during phaco. So, let me tell you in the beginning itself, it need not crack always. There are other ways of doing cataract surgery. But still, the phaco chop is the best way to deal with most of the cataracts. So that is why we tend to chop all kind of cataracts. So if it doesn't crack, let's go to see moderate cataracts, grade 2 to grade 3, they all usually crack. If your technique is fine, they will get chopped. But very hard cataracts. So we will just see how it is normally done. So this is a speeded up video without editing. So I will stain with trypan blue all these kind of cases which are hard and which don't have red glow. And after that, a capsular excess, very important, more than 5.5 for sure. And remember that this is not going to stretch as much because of the fibrotic nature of the whole lens. The capsule also is less elastic. So don't think that this will stretch like in a young patient. So hydrodissection may not be required because it is just the whole nucleus sitting inside the bag, but you can do a limited hydrodissection and start off. See, the tip is sharp, new. The chopper tip is 2 millimeters long. Don't be scared about long chopper tips. Nothing will happen. It cannot hit the capsule at all. So now, using adequate energy, it depends on your machine, how much energy you should use. It should go into the nucleus when you hit your foot pedal. That's it. Not that you should use only 30%, 40% or 90 is not good. Nothing. If the energy is directed into the nucleus and your phaco happens inside the nucleus, nothing happens to the endothelium. So once it is split, have the hold. See, and the vacuum which you should keep, not always very high, enough to hold the nucleus and not to have surge. That is the most important thing. Many machines have surge and you don't know when you will get surge. And at that point, if you get surge, reduce your vacuum and do it in a comfortable 250, 300 will be more than enough. And hold it well, and your foot pedal control should be very good. Don't go into 3. Always remain in 2 when you are chopping. And once you chop, make sure the chop goes through to the bottom, through the posterior plate. And then these individual pieces will be easy to aspirate. If they are connected to each other, you'll find it is very difficult and the tip gets clogged, it doesn't come to you and all those things. And also the tip which you use, if they are smaller tips, then you will need to sub-chop these nucleus to the size of the tip which you are using. If it is a large one, it will eat faster, but you will have more surge, remember. So once that is done, you can do all these kind of cases easily. But then the situation comes if it doesn't crack. So ideally, I would do a trench to visualize the red glow very well. So red glow seeing is very good that you are close to the posterior plate. That is one indicator. So holding onto the lens and chopping, it is usually a vertical chop, but I combine it with a little horizontal movement also in very hard cataracts. And then make sure it splits in the periphery. If the center doesn't split, make sure it splits, and the periphery will easily split. So visualize the peripheral split and have the hold on very well. And once it splits in the periphery, then we can manage the separated piece partially. We can emulsify. This is called the flower petal, or different names they tell. Bring it outside the bag and then eat off manually from the neck and leave what is there behind. So move it forwards and eat off from where you have held, but then don't do it within the bag. If you do it within the bag, you are too close to the equator and you will hit the capsule. So hold it, bring it towards within the rhexis margin area, and then emulsify whatever is available at your tip. So continue, slowly continue. Each time you go in, some part of the center part may come out. If it comes out well and good, you can take out and eat off the part of the nucleus which comes out. But the posterior plate, which is really leathery, really hard, will stick on. Let it remain like that. Don't chop. And after you finish off all the periphery, you will realize that this is a disc of lens. It can be held, lift it up, and then eat it off as and when it comes. Not when it is flat. If it is flat, you will go through and through because it is a thin plate. So thin plates are lifted up and use lot of viscose, or Indian companies are also making dispersive viscoelastic like Apasami, like Oro Lab. All of them have cheaper dispersive viscoelastic which will protect your endothelium. Reuse them, reintroduce viscose multiple times if you want during your surgery, and don't hurry on this surgery. Be slow. And this is how you can manage. Then comes soft cataracts. So initially we will think that soft cataract is easy. So we will later on realize that soft cataract is more difficult to chop or bring it out of the bag. So there are different ways of dealing with soft cataract. So what is the problem? So once you try and catch, it eats off. Wherever you hold, it eats off. And it eats, suddenly it may go into the periphery. And whatever hold you have is gone. By attempting 2 or 3 times, the central small nucleus which is there also is gone. So then you will have a bowl. I remember my third case in phaco training became a bowl like this. And then I asked my trainer to please do. He came and he said, why just flip it out and do it, man? Then I said, you please flip it out and do. If I try to flip, I may hit on the capsule. So it is not as easy, and you should be careful when you are less than grade 2. So here is one way. So hydrodissection and rotation is the key, is what I feel in soft cataract. So do a clean hydrodissection, then press on the opposite side and let the fluid out, and then do multiple hydrodissections and even a delineation if required. Delineation need not be done, but then still if possible please do. And then the tip is little longer. If you see, the sleeve is little back now. So go one tip width deep till the posterior plate, and then split. Rotate. If it is not split fully, rotate with 2 instruments. Rotate. Don't hold. Just use one hand your chopper and the other hand this one, and then 2 pieces are free. Now go hold the edge of this one, have the vacuum rise up, and you will see that this piece comes into the anterior chamber as easily as you see. So don't use energy. That is the most important thing. Go near it, use vacuum. You will hear the sound of vacuum building up. You should hear. You should use your ears and keep the volume high. And deaf people like me will need to have it raised up like that. But then you should listen to what the machine is telling you regarding vacuum, and then raise vacuum and then use judiciously. Again here, you can chop from the periphery. This is a chopper which is 2 millimeters long and is less like your little finger. So support it here and don't try to hold. If you try to hold, it will eat off. Just along that hole there, which is the burrow there, just support it with your phaco probe and then pull along. Do the horizontal chopping. But the problem is that you may go superficial when you come to the center. So remain deep. Don't worry, this is not going to hit your PC. This is the doubt which everybody has. It doesn't hit PC, and also it is a very blunt thing. It doesn't go. It is 2 millimeters and it doesn't go close to the PC. So once it is divided like that, then use more vacuum, bring it out and finish off. The epinucleus plate can be just aspirated even without phaco energy or a little bit of phaco energy. So that is one way. So see another way. This is another soft one. So hydrodissect very well. Rotate very well. A delineation also can be done. If not, I don't insist on that, but delineation automatically happens. And then while you keep rotating, you can prolapse up one pole. With very soft cataract, you can easily prolapse. This is the lens salute technique. One pole comes out. This is not very soft, but still it could be prolapsed out like that. It is just rotate a few times and tap on one side, the other side will come up. just like you are doing SICs and trying to prolapse. And then you can eat this off. Just go into the center and then chop from behind. Otherwise, you can just eat off from the top part which is outside, rotate out and eat off. You can continuously just eat off without any chopping. So once that is done, this is only a half of this thing left. And if it is choppable, please do. But if it is softer than this, you can just keep phacoing it with vacuum and it comes off. And yet another way is to the initial chop which I showed you. I have learned it from Dr. Netto, Sunil's great friend. So he calls it wedge chopping. So use the tip of the chopper. You will always be using some beveled tip. So use the bevel to approximate the chopper towards the bevel tip. So this will act as a dagger kind of thing which will easily split. And also remember, your my hand, second hand is almost 90 degrees away from the main incision. That is very crucial. The chopper instrument should go towards one corner, not at the nasal side. So that is very crucial. And once that is done, you can use the second instrument again to move the pieces out of the bag. So trying to go and hold it again and again, it will keep on eating off. Then you will go very close to the equator. So if you go very close, you can eat off the capsule. So use the second instrument and try to bring it out of the bag. This is a very blunt chopper, you can go into the bag and easily chop off. And at the end, I will show you this technique, which is also very much possible. A very good hydrodissection, a very good rotation, and a 5.5 rexis. See the vacuum. Always vacuum on and then have energy continuously happening, but the tip is always buried inside. Don't go very deep. And once it keeps coming out, you can keep on aspirating, but tip should almost always be occluded with the material. That is what is crucial. You can see here, vacuum is always on, but no surge at all, because this is a stage which doesn't give me surge. So people always ask, how does the nucleus rotate? How did it spin? There is nothing magic about it. When you spin it with your hand, with your chopper, it was rotating. When you hold it with vacuum and eat off a little bit, the natural tendency of this thing is to rotate. It will rotate and come out like this. So this is not an accidental thing, or this is not just a fluke. It happens as a technique. So I can show you multiple videos like this, but then this is one way you can do. Ozil works very well in this, but if you have a hyper pulse mode, that also will work in your regular longitudinal phaco. Thank you very much.
I'm next to you.
Okay, sorry, I thought one of you will announce. Anyway, I will thank myself for the talk. And then
I think we heard one of the masterpiece talks now, and such excellent teaching tips he has taught that I felt I had learned so much more. So 3 cheers to Dr. Meenumathan, and he'll carry on with the other topics.
okay, thank you very much. And we'll now call upon Dr. Sudeep Das. He is a very senior phaco SICA surgeon, now mostly doing phaco. He is now back to Kerala, and he is with us in Kottayam. And he will talk to us on zonules. What happens? Zonules are weak or broken. So this is one of the most dangerous situations which any phaco surgeon can face. Over to Dr. Sudeep.
Not back to Kerala, first time in Kerala.
Correct, not back to Kerala.
So this is of course a very old video, that's why the quality is like this. It's the strangest zonal dialysis I've had. So basically what we are taught, when you do a hydrodissection, we go and inject on one side, and then when we come to the opposite pole, we depress the nucleus and we move it towards the original site. Okay, and here the patient also decides to, so I go in, I do my hydrodissection, then I come to the opposite side, and the patient decides to help me by lifting his head. And the zonules on that side go down. So anyway, so I just put in a CTR and finished the surgery. Fortunately, the rest of the zonules are all right. This was another one where I was called in at this stage. This was a fellow surgery. So very senior fellow, almost at the end. And then he had a zonal dialysis. The vitreous was there at that point. So this is where I take over. Unfortunately, the previous part wasn't recorded. So I decided to put in these iris hooks, and if you see, the iris hooks are going quite scleral. So they're not tenting up the iris at all. They are at the level of the iris. And then so 3 of them here. The rest of the zonules seem to be all right, and it's a very black cataract. And of course, you cannot do anything without doing an anterior vitrectomy. This was in the olden days where the vitrector was 20G. So once it's done and the capsule is supported by the hooks, I can sort of proceed and complete the phaco, do a direct chop and complete the phaco. I could have possibly used more hooks to just dilate the pupil a bit more, use some 3 more or 2 more hooks. Ideally, I should have, but then it went on well. So basically, the zonules are not there. The hooks are supporting the back. The hooks are taking the place of the zonules. And of course, you have to use a lot of viscoat because here you tend to work a little more anteriorly. And at this stage, because part of the nucleus is gone, the support is not there, the equatorial support. So I decided to put in the CTR. And this video is also speeded up. And I usually use the micro-rhexis forceps instead of a dialer to insert the last bit. And now, of course, the bag is completely stable. It's not just supported, the equator is also stretched out. In the brown cataract, initially when you start, till you remove a few pieces, the bag will remain stretched because it's such a big and heavy nucleus. But once some of the pieces are out, you need to put in a CTR. Otherwise, it's not just the edge which is supported, the rhexis. The equatorial part will start coming out. Well, this supports that. So once that is done and I have a CTR in place, I can put in any IOL of my choice into the bag and then remove that. And of course, I have to check again whether there is vitreous. This was another strange case. It was a hypomature cataract. And when I injected, that's when I started recording. When I injected blue, I realized that part of it wasn't staining. Till the time, there was no suspicion that it was slightly subluxated. It hadn't been seen in the OPD. And it's a white cataract, very difficult to see. So before I do anything, I do a vitrectomy there. And I haven't even done my rhexis or anything at this stage. So you have to have your eyes peeled out. I mean, if you think that, you don't notice that, then you'll end up in real disaster. If you don't realize that why the capsule is not staining is because of vitreous. And you can see the capsule is pretty mobile. When I'm doing the rhexis, the whole capsule seems to be moving because a lot of these hypomature cataracts, the nucleus and everything shrinks down, and the zonules are also not very great. And then, of course, the CTR goes in, and I'm inserting it to the side of the ZD, suspected ZD first, because I'm hoping that the rest of the zonules are better than this side. So always inject, expand the side which has the zonular dialysis first. And then, of course, the cataract is not a very hard cataract, and there's nothing very different from this stage. But you have to be gentle. If you see, I'm not really stretching it much. Normally, I would stretch the nucleus a lot more. But here I'm trying not to stretch because that itself will put some pressure on the zonules. And this is, as you can see, it's a really leathery cataract. And I've got a split. This is again a long chopper. And so I'm using viscoat. And after I finished, I suddenly realized, what is that piece doing there? And you saw the surgery also, there really wasn't anything to show that there was a zonular dialysis. And look at the amount of the size of the piece which has gone in. And again, that area just closes. There's no vitreous, there's nothing there. And you had these enormous two pieces which were there, which had gone through a sub-incisional ZD and were in the sort of just. And I think I removed everything, but again I see a shadow there. So I go in with Visco and again go through the equator, and there's another piece. And you see the ZD is not really very large, but somehow, and normally we have eyes on what's happening, and somehow I missed these pieces going behind completely. So I put in the IOL and then for safety and then remove this piece. So I don't know whether there was a pre-existing weakness there, because where I would expect the least manipulation is, and I haven't sort of pressed down the nucleus at all at any time at that point. And sometimes what happens when we have cataracts like these, we finish the nucleus management, and then there's like a, we relax, and that's when we catch. So I've caught the capsule there. So since I didn't have a CTR immediately, they were getting the CTR, I thought, okay, let me put the IOL and that will expand the bag. Unfortunately, the haptics didn't, plans don't go according to what you think they will. So I thought the haptic will expand the bag, but the haptic didn't open at all. They're like doing a handshake and they're stuck there. So then anyway, by the time the CTR came, I inserted the CTR, I released the haptic and the cortex. So the take-home message is that you have all the tools needed to handle whatever emergencies you have during surgery. And the ZD can happen at any stage of surgery, like I showed you. And watch out for subtle signs of ZD. So you have to have the CTR, hooks, iris or capsule. Capsule is theoretically better, but I somehow prefer the iris hooks. Have dispersive OVDs, Viscot or any of the Indian substitutes. And you have to have always in the OT have a working vitrectomy cutter and a range of 3-piece IOLs and the presence of mind. Thank you.
Thank you, Dr. Sudeep. See, he is a very cool surgeon who manages difficult situations, difficult challenging situations very coolly. I have seen him do, and I used to wonder how he can be so cool when they have this. So thank you, Sudeep. Come. So next talk will be by Dr. Chitra Ramamurthy while she is getting ready to tell us on how to deal with an open capsule. I just want to stress on one or two things in the subluxated ones. When the use of dispersive OVDs, that has been very much under rated, because it will remain inside the bag and it will act like a nucleus piece. So if it remains there in the bag, it will open up the bag and keep it open unless you go there and aspirate it. So when you are doing a surgery, your aspiration flow rate has to be low. Bring it down very low and do slowly and refill the bag with dispersive OVD so that the bag remains dilated till you get your CTR inside. CTR can be delayed as long as required. And the availability of these kind of instruments like micro scissors, micro forceps, CTRs and these rings, all those things have to be kept in a accessible place. As he was telling, searching for CTR where it is, so let us put IOL. So that feeling should not come. We should be doing it meticulously with everything available on call. Thank you, and over to Dr. Chitra.
Very good afternoon to one and all of you. I'm sure all of you are awake. Meenu Mathan's session deserves 200% attention of ours. And I'm really honored to be a part of this wonderful meeting which he conducts year after year. My due is to tell you how I dealt with some of the PCR moments. There are a huge variety of them which happened to all of us. And there is one controversial video which is also there. You can have your thoughts on that. Now, when we have a PCR, the first step for us is to do an anterior vitrectomy. And today we have different machines, modern machines have a cut IA and an IA cut mode. So in the cut IA, what you have to do is you have to start with the irrigation, and the second step in the thing is a cutter. So what it does is, it makes sense, there is vitreous there, so you need to cut the entire vitreous. Of course, you have tricot today which helps you stain, but sometimes you can do the preliminary part of the cutting without the tricot being there too, and check with the tricot in the end. And after you cut, then you have the cortex there, then you can go on to the IA cut mode. So in the cut IA mode, you need to have the cut at the maximum that machine offers, like 4000 my machine, a moderate vacuum of 350 and a low flow rate. And then when you go, now you have only cortex there, then you go into the IA cut mode, wherein you go into the foot pedal 2 and you aspirate all the cortex. Again, if while aspirating the cortex you feel there is vitreous there, then you go back to cut IA mode. Now I am going to show you one case here. Now this is a typical polar cataract. You see that clearing, there was a PCR. I have removed the nucleus. So now I go on cut IA mode and I go and remove all the vitreous, and then I go into IA cut mode. I could even do a dry aspiration without irrigation, and I keep replenishing with viscoelastic. And again I notice there's little vitreous, then again go into cut IA mode, then go on to IA cut, wherein I strip all the cortex. I can even cut the epinucleus so that I can get it all in one chunk. The ease with which comes, there is no traction, you know you're fine. But therein again a suspicion comes that there is vitreous, then you again go into the cut IA mode, cut all the vitreous. And the ease with which you can remove the cortex is an indicator that you have done a complete vitrectomy, and you look for the full support of the rhexis, and then you place your 3-piece IOL on the rhexis. Now we have the tricots available, which I use it as 1:10 dilution. Here now the IOL has been placed. I have no clue that there's a small PCR there, but I see that knuckle of vitreous at the incision. So then I go in at diluted tricot, I inject, and then I see that clearly that delineates the vitreous there. So I then do a vitrectomy and remove it, but then I don't go searching to look at the extent of the PCR. The lens is sitting well, it's stable, and I close my case. Now this is the first case which I am going to show you. Now this is a well dilated pupil. Now moderate size rhexis has to be created, you stay in the capsule well. So everything is going quite well, and then I've started chopping. Now sometimes, as Dr. Minu had said, the posterior plate may not cut separately, but anyways, my due is to discuss how I bring down my parameters to the last piece, because I know the PC is already well exposed, it can get trampolining into the probe. So then lower the vacuum parameters, things are going good. Now when I remove this cortex, I don't know whether you are able to see, there is a small oval PCR, a circumscribed PCR which has got created. No vitreous face is not disturbed. I inject viscoelastic to push back that any possible vitreous which could be there. And once I inflate, then I go in and inflate the bag. There's no cortex left. So now I'm going to inject my single piece IOL. Now that's just a focal area of PCR with no vitreous presenting. I don't see any need to disturb this vitreous face. But the tricks are, should not be rotating the lens. I should be injecting it into the bag to what extent possible. That there is a trouble I'm having in getting this haptic into the capsular bag, but then again I would not rotate it. I would gently nudge it in at that particular position. It's a toric IOL, so I'll nudge it into position, all the time being careful that I do not exert any pressure on the capsular bag, remove all the viscoelastic, and then yes, I would inject tricot to see whether I have disturbed the vitreous, which I have not. I get further clarified. However, I just do a gentle anterior vitrectomy for whatever it's worth and remove the tricot and get done with the case. Now this is the second case. Now I'm sort of lost attention, and suddenly there's anterior chamber shallowing, and there's a sub-incisional PCR, and the nucleus starts dipping in. Now I know it doesn't look very good and aesthetically good, but I have to get this piece up. There is no vitreous as of now presenting, and I inject viscoelastic, get the nucleus right up, just enlarge the incision, because the plan of action here is to place a 3-piece IOL as an IOL scaffold. I'm not clear about the extent of the vitreous with PCR. If I cannot visualize anything, I can leave the haptic on the iris, but if I get some clearing as I can now, I position the 3-piece haptic in the sulcus. There is a lot of vitreous there, but first my work is to do phacoemulsification. The lens will keep all the vitreous in bay. There's nothing much to worry there. And once I've eaten up, after of course coating the back of the cornea, I go behind and do all the cutting which I earlier described, cut all the vitreous, and check whether there's vitreous in front of the IOL. And once I feel I've cut adequately, this is not more concentrated tricot, but anyway, the tricot has to be diluted and cut it. And once that is done, I ensure it's well positioned and that case is done. Now this is case 3. Now here, it's a very soft cataract, well dilated pupil. I've nearly removed everything, epinucleus, then I see that small flap right in the center. Now I could have converted into a PCC, but it's too small a flap. So what I do is keep my phaco probe inside, go in through the side port, inject viscoelastic to push back the anterior vitreous face so that it's not disturbed. And then I'm going to inject my single piece IOL very gently into the capsular bag, just the way I said. I will not rotate the lens. I would gently nudge the haptic into the capsular bag. I would not overly stretch. I would not disturb the vitreous face. And once I have gently rotated and nudged the thing, now I'm going to go and strip all the cortex which is there. So here again, this IOL is acting like a scaffold, and then it is easy to remove. And there's no vitreous, so you can see the vitreous cortex is coming off easily. This is a very old case of mine where the patient had a centered IOL, came in later with this kind of a subluxated IOL. And now what have I to do? I have to get this out and place another IOL on the rhexis. But I don't just pull it out. I have to go behind the lens, do good vitrectomy because I cannot exert any traction on the vitreous base. Once I've done the vitrectomy, this is a very old video, so I would have injected tricot in the present day. I get the haptics out of the capsular bag, and once the haptics are in the sulcus, I would again go back and inject viscoelastic to coat the cornea and deepen the anterior chamber. I enlarge the incision just a little bit. And in this, I go and cut halfway through. If it's a hydrophilic lens, I can just pull it out hand over hand technique. I can cut it right through or I cut it half. And then again, hand over hand, I remove it. I'm paucity of time, I'm going to go on. Then I would inject viscoelastic, place a 3-piece lens in the bag, in the sulcus, and then I would check for any vitreous and cut the vitreous and get out of it. Now this is the case which is going to be a controversy for you all. I thought it was a well done case, high myope toric, the patient was going abroad, out of station in a couple of days. When I see something was wrong, the lens was tilting. So then I realized that no, there's no PC at all. I was quite wrong. But I did not have a battery of lens. He was a high myope. So what I do is I have to first get this IOL out because it was dangling in the vitreous. So I go in with my 2-inch dialing hooks. It is upside down, but however, I get it right up. Once I have done this, now I'm going to go behind the lens and do a good anterior vitrectomy, ensure that I've cut all the vitreous. And then once the vitrectomy is done, I have to go in, inject viscoelastic and turn the lens up so that the haptics are well positioned. Now, I explain to myself, he's a high myope, he has a deep anterior chamber. So this haptic, though a little bulky, can be very well placed in the sulcus. It's not going to rub there. The challenge is in an undilated pupil state, the pupillary rough can rub on the optic of the lens and create pigment dispersion and intraocular pressure and CME. So here what I do is, after I wash off all the viscoelastic, I do an optic capture which sees that the optics is behind with just the haptics in the sulcus in a deep anterior chamber, and this patient continued to do well, absolutely bang on axis, 3 months, vision of 6.6 and was absolutely fine. Now this is the next case scenario. There's a PCR and there's a polar cataract and there's a strip of PCR, the typical one. I do an anterior vitrectomy, and once I have done that, I'm going to now, again it's a toric IOL, I've promised the patient. There's enough place up and below. It's not a 3-piece IOL which I can force in. I gently nudge a single piece IOL on the remnants of the PC above and below. And once I've done it and position that haptic to sit on that PC, area of PC which is there, I'm going to go behind and get the optic out. You need to have a smaller rhexis for this, and this is what we would call as the reverse optic capture. And again, then I ensured it is bang on axis, and you can see this patient, reverse optic capture, 6 weeks, is absolutely bang on, 167, the previous eye 168, it's 1 year and these patients are coming, they're absolutely fine. This is the last of my case which I'm going to show you. Now in this, in this particular case, this was a patient who had had a complete vitrectomy done, and it is like operating on an open capsule. There is that area where there is a lens touch which has caused the cataract to form. So first and foremost, I would make a small rhexis, and then I would do a hydrodelineation as I would do in a polar cataract,
and I nudge this small piece of endonucleus out, and then I eat it up with phaco. And now it is just that epinuclear shell there. So I'm going to do a visco dissection, go into the capsular fornices, then grasp my epinucleus at tip, and it comes all rolling out. So everything has gone off well. Now all I have is just some cortex to strip, wherein, if you look carefully, there is that suspicious area on this temporal side. And I keep stripping, but there's no vitreous. I mean, there's no vitreous anyways, but then you can see that shiny silicone oil bubbling up there and coming there. So I wash it off along with the cortic aspiration, which I'm doing here. And then I place my 3-piece IOL onto the sulcus. This patient was anyway posted for a phaco and a removal of silicone oil. So I remove all the silicone oil which is there in front and leave for the vitreous surgeon to remove what is behind, and thus this case got completed. So that there are any number of ways, and so many ways each of us know. I just put together a few of them for you to understand that these are some tricks which we use to get Bale SRs out and yet implant an IOL in the bag or in the sulcus. Thank you very much.
Thank you, Dr. Chitra. What a master class on PC rents, the different settings of PC rents and the ways to manage it to get a successful outcome. And she has shown post-op cases later. That is what is important. So we just do something and leave it, and later on what happens, we don't know. So if they remain like uncomplicated cases, those are the ones which have been managed very well. Congratulations. Thank you, Dr. Chitra, for sharing all this with us. We didn't see anything controversial. We don't want to discuss anything controversial. Come. So anyway, two things if you would have noticed carefully, even in the last video, the aspiration rate was very low. Reduce the aspiration rate, reduce things being pulled from different areas when you have a PC rent or a zonal dialysis, and always use dispersive viscoelastic into the area where you do not want things to come towards you. PC rent, plug it with dispersive. Zonal dialysis, open up the bag and push it away with the dispersive. These two things, keeping in mind, will change the scenario drastically in your practice. Thank you very much. And we go on to Dr. Matthew Kurian, the Master Cataract Phaco Surgeon, now from Cochin, and he will talk to us. The IOL is now stable. PCR is over. IOL is unstable. What next?
So this is a very simple situation where the lens has gone through, the haptic has gone through the rent which was there. It was rotated a little bit and then the haptics have been pulled. These are multi-piece IOL. So haptics have been pulled up into the sulcus and placed there, and it will be stable there. The rhexis was large, so an optic capture could not be done. Next one is flax, where here this is a blunt injury. There is a dialysis superiorly, and it is more apparent during the IA. And at this stage, there was no suspicion that this would be having anything other than a dialysis. So the plan was to put a posterior CTR. But then there is also a posterior capsule rupture. And at this stage, what I do, maybe something little controversial, is to place the haptics into the sulcus and do an optic capture through the rhexis margin. This was one of the early cases of optic capture in a femto IOL, and it looked in a femto cataract, and it looked very stable. 5 years follow-up is there, and that's good. This is something which Dr. Chitra had just shown, reverse optic capture. But the reason why this reverse optic capture was required was, you see the leading haptic, it was bent over. It should have been straight, and it would have not caused any problem. It was bent over, and so there is a little time as it is unfolding when it is still like a knuckle there. And up to now it looks good, but you can see that when you are dialing, it just goes off very much into the periphery, and that bent knuckle actually hits the posterior capsule and creates a rent. You can see over here that one flap there, which is part of the posterior capsule rupture in the periphery. So at this stage, what we do is a reverse optic capture, which just now Dr. Chitra had also very beautifully shown. And this is again a very acceptable and stable method of separating the anterior segment from the posterior segment. Here you can see is a IOL misadventure. The plunger is overriding a large portion of the optic, and the cartridge is stretched. lot of force is required to deliver the lens into the bag. And at this stage, as the trailing haptic opens, you can see that there is significant amount of trauma there, which I thought would be okay, but 1 week post-operatively, that haptic was in the inferior angle with corneal edema, needed to be replaced. This was like government takes TDS, what I call as haptic deduction as source. This is very easy. It's not going to stabilize anyway. You have to exchange this. And one of the methods of exchanging, explanting this IOL is to use 1S or preferably specialized IOL cutting forceps, which are essential for hydrophobic lenses, where you bisect at least halfway, and then once you've got a 3 millimeter cut, you can sort of rotate the lens out of a 2.83 millimeter lens incision and take it out. What is my preferred method of IOL exchanging now is, in this case, I am not sure what exactly has caused this lens to dislocate so much. So I am making a full SICS kind of wound, do the anterior vitrectomy, clear the vitreous from in front as well as from behind, and I know that there is a large rent there. Once the vitreous is cleared up, I want support, so hold the IOL and then explant it. And now I examine, I could have done this, I should have probably done this initially itself, use the hooks to see what exactly is causing the problem. I see adequate rexus support is there, and the rent is only a small central rent over there. I am able to place the rigid lens in the sulcus. Unstable IOLs, if it is a closed C-loop IOL, you can do an in situ suturing under the flaps, very old method. Now I use scleral pockets and have gradually moved from temporal, the peripheral to the central approach to a Hoffman's pockets. And here I am doing an in situ bag IOL suturing through the fibrosed portion of the capsule very near the haptic optic junction, and that will give adequate support to stabilize this lens. The 90 proline is used, and it is sutured and goes into the scleral pocket. This is primarily a CTR was done for a blunt injury. Secondary dislocated, I am putting in a CTS at the area, the CTS is anchored at the area of maximum dialysis, and this is the method of in situ bag IOL complex fixation with capsular segment tension, capsular tension segment or the Ahmed segment, and I have increased the tension too much on one side, the whole bag complex moves to the one side, and I decide to put in second CTS, and this also goes into the bag and is sutured. Now what has happened is, in order to give good tension, I have put the knots a little bit too tight and it gives way, and about a year later I had to do further gymnastics with this case. And this time, instead of using proline, I decided to use more robust suture. So this time it is Gore-Tex. I thread it through the eyelet of the CTS in situ, and this is the entire CTR bag IOL CTS complex refixation, and that also finally ended up giving a stable, decent vision to this patient. Now the question is, are all these gymnastics necessary? It's up to individual choice, and right now, as I have grown older and wiser, I tend to be a little more conservative. So this was glue dial which was performed, and about year and a half, 2 years after the glued IOL, the haptic has macerated the sclera over there. That sclera is looking quite necrosed, and that haptic has slipped back. So the other side is fixed well. So I've just exteriorized it. There is nothing in which to tuck it, no pocket, nothing. And at that time, flanging, this is before flanging techniques were there. So I just sutured it and put a scleral patch graft to close the place. This is what I do now. Support, anteriorize, bisect if required, remove the bag IOL complex entirely, and I do Hoffman's pockets. Thank you, Dr. Sudeep. He's the master of the Hoffman's pocket. And once I do the Hoffman's pockets under a AC maintainer so that the chamber is always pressurized, you can use a toric marker to ensure that it is diametrically opposite, 1.5 millimeters behind the lens, limbus, and I make sure that I am using the needle and ensuring that the Sinski is basically to ensure that the pocket extends beyond the area where the needle is entering. And this is my current favorite, the capsular CMT flex goes in through a 2.8 incision. The T-shaped haptic is exteriorized. For the second trailing haptic, I use a handshake technique, hold it close to the T and exteriorize, and use some counter pressure to exteriorize and get the T out. And once you have the T out, go through the pocket with the Sinski hook and gradually draw the T portion into the pocket so that externally it looks very clean and the T itself closes the hole. One thing that you have to remember is that if you are entering with your hands supinated, it should come, both should come supinated. You should not enter the eye with one hand supinated and come out pronated, because then the lens will be tilted and that's what will happen. It needs to be fixed. Thank you.
Thank you, Dr. Matthew. Thanks for showing all those and telling that when you grow wiser and older, you go more conservative. See, really, everybody should learn from that, and don't make your own mistakes and wait for you to become older and wiser. We become now itself wiser. What is the problem? So believe that lesser manipulation is better, and the technique which works in your hand will give you best results. Don't look at what somebody is doing, let me try that and see, and all those things. So thank you, Matthew, and we'll move on to the last talk. Dr. Sunil Tangaraj. He is a very good friend. He is a very senior surgeon. He operates in places where you get the most difficult kind of cataracts, and he is a master SICS surgeon also, and does lot of difficult phaco's, and so he knows when to stop, and if need to stop, what to do. Yeah. So over to Dr. Sunil. He is from Vizag.
Yeah, thank you so much, Minu, for inviting me. This is my first KSOS and I'm enjoying it. And without much ado, I'll go ahead. Now, there are situations when you don't even think how to proceed with phaco. When you see situations like this, don't even do phaco, okay? Such type of cataracts, just go ahead and do an alternative technique. Now, when proceeding is tricky, now when you see the first video there, when you get that snap sign, that tells you please convert. I mean, great surgeons will say you can do phaco. Please don't try. Moment you go in with your handpiece, the nucleus may sink. Okay? And if you are in trouble, that's what's going to happen. Either you'll get a corneal burn or you'll have to send it to the retinal surgeon. Now, sometimes some surgeons, they keep doing, drop it and hand it over to the retinal surgeon. Oh, I need the audio for this. So don't do that. Don't get into that. You do some other alternative technique. You can do ECC. It has a lot of disadvantages. And you can do all these other techniques, SFIOL, IOS, claw, ACIOL, all that is later. Okay. My best go-to technique is just convert to SICS. And sometimes, yes, when I say ECC is redundant, it's not exactly. Sometimes you get a case like this, two blebs on top, no no space superiorly or temporarily. It's a hard cataract, one-eyed patient, subluxated lens. Sorry. Can I just play this video? Yeah. Yeah. So here, this case I did, I think, in some 2 decades. This is a clear corneal ECC. But these indications are very, very few, okay? But when I say ECC is redundant, doesn't matter. It is, doesn't mean that I'm saying it cannot be used. Certain situations, of course, you will use it. Now, see, these are the situations where I'm trying to convince you that SICS is the best bailout technique. Sometimes you get this Argentine flag sign. Yes, you can do phaco. I'm not saying you can't do phaco, but the safest alternative is SICS. If it has gone across, or if the nucleus is extremely hard, then you don't want to do a phaco in such a situation. So it is safe. Then this situation where I have done this, a very hard cataract. The rhexis has extended inferiorly. Now, this is a situation you don't want to take chances. I've done a transconjunctival SICS here. I didn't even try a phaco. See, that's such a hard nucleus. If I start separating, all the chance that is going to go down. So don't take a chance. Go ahead, do a safe SICS, shake hands with the patient tomorrow, and be off with him, okay? And this is similar case. Here, I have lost the rhexis superiorly. When I lose the rhexis superiorly, I still continue with phaco. Okay, I kept continuing. I scalloped the border, got enough rhexis, started doing the phaco, and suddenly I had a doubt that it's extending. When you have a doubt things are going wrong, please stop, think, and do what is safest for the patient. Don't continue. You may regret it. So of course, it hadn't extended. Of course, in this case, I could have continued. And in a case like this, when the nuclear disassembly is already done, it's a little more difficult to get out the pieces. You have to do a visco expression. And this is another situation, very hard cataract, subluxated. I'm doing the phaco. Nothing is happening. It's almost at 100%. So I converted to a SIC, and look how I've got buttonholing almost entirely. Superior incision, I've got a buttonhole. No panic. Go ahead, just deepen that incision, make another tunnel below it. Okay? And go ahead and bring out the nucleus. Later on, I realized that my handpiece was defective. I did not know it on the table. Nothing was happening on the nucleus. Although I was at 100%, nothing was happening. Okay? And this is another case. This is a phacolitis. Similarly, Sudeep showed you a case like, see, I'm trying to pull the thing, the whole bag is coming out. I tried to give counter traction. Even then, I could not manage the rhexis. So in a case like this, don't bother. Just convert. Took out the capsule itself, put in an iris claw lens, and you have a good result here. Okay? So SICS is an alternative technique in such situations also. Now the next situation here, I actually did not realize that I am almost going to get a Titanic. Okay? Immediately converted, then just did a posterior levitation with some viscoelastic, brought out the nucleus, reconstructed the nucleus outside just to see that I've got the entire thing because it was already divided, did the vitrectomy, took out the cortex, and here happily you can put in a PMMA lens or you can put a 3-piece IOL. No big deal. And this is, of course, I've got the Argentine flag, it's extended. I went ahead, finished the phaco, put in a lens. I'm very happy, I put it in the bag. Great, and look what happens. It's going down. And here, yes, you can cup the IOL, you can do all sorts of things. But the safest thing here, this is a diabetic, anti-hyaloid face intact. Safest is to make an SICS incision and gear it out and put in a lens. I've been following this patient for 3-4 years now. I'm giving him regular intravitreal anti-VEGF, and he is quite stable. So in conclusion, when things go south, always have a plan B. And in fact, I think you also have to have a plan C. You know, when things go really south, have a good vitreoretinal surgeon friend, okay, to bail you out. And always keep safety and outcomes as a top priority. And in my opinion, and I think it should be in your opinion, SICS is the best bailout technique when things go wrong in phaco. So, I don't know what's happening. Anyway, that was the thank you slide. Thank you very much for your patient listening. I hope I finished well
Yeah,
here.
you have finished well in time. You play the thank you slide, please. Yeah.
So what I believe you were trying to say is thank you.
Thank you.
You're welcome.
Thank you, Sunil. See, the thing is, what he said in between is very crucial. See, yeah, I did not know what was happening. I could not identify those are the situations where things must be going wrong because you have been doing phaco for such a long time and things don't happen means either machine is faulty, if machine is not faulty, there is something losing support here or something. So at that point, if you try to continue, you may end up with a problem, and the safety is what matters. Everybody in the panel agrees that dealing with things safely is what matters. So converting to an SICS incision made properly, not like in a hurry extending the clear corneal incision and then suturing and all those. So all what he showed is change the location and do a scleral tunnel and then take out the lens. So inferior, very crucial point, inferior rexus tears, all those things do not attempt. I do not attempt. If I get a rexus tear inferiorly with a black nucleus inside, I do not attempt phaco. So please be safe, and for that we will have to practice doing a scleral tunnel. So that is very important. And some people say, okay, so difficult, or just do an SICS. So somebody cannot just do an SICS. You have to be good with SICS to do a complicated situation without creating further problems. So that is what will bring out the best to the patient. So your comments, Sudeep, please.
Yeah, I agree fully. When you're looking at one of our videos, all of us have decades of experience. So we probably can make out the slightest tremor of the nucleus, like I was doing a PPC just a few days back. And it wasn't dividing, and then fortunately, before it divided, I just noticed the faintest of tremor. It wasn't tumbling, nothing. And then I just converted and I realized that there was a PPC. But when you're early on, you won't recognize all that. So it's probably best to be safe rather than being sorry. So when it's a difficult situation, don't think if you haven't already done it a lot, you haven't practiced it, don't even attempt it. Just do something, whether it's ECC, SICS, whatever, convert to something you are safe, you are accomplished in.
I think the whole instruction course was wonderful with teaching us tips along the way. And I think, as was said earlier, I would never want to do something more complex as to conserve a bag beyond what it cannot be conserved. So I would actually, in the easy cases, I go ahead, do a good vitrectomy, remove everything, and do a good iris clip lens and get myself out of these moments. And if not, otherwise, I hand it over to my vitro-retina people to handle it. And SICS is a wonderful bailout situation in some of these very critical situations which Sunil showed us. That was all very nice, Sunil.
I have a couple of points on converting to SICS. One, if you have done a pure clear corneal incision, it is practically impossible to convert that to with back cuts to a proper watertight SICS wound unless it has to be sutured. Okay, so if you are starting a potentially problematic case with a sclerolimbal incision or a near clear corneal incision, that can be converted with less amount of challenge, and sometimes it can be left unsutured also, the wound will be stable. If it's clear corneal, the preference would be to just suture that wound, close it, and move to a superior incision or another location for the SICS conversion. All these situations in an intact globe, creating a tunnel is pretty much easy. But when the globe is already open, maybe vitreous is there, the globe behaves very differently, and learning to create a tunnel in that situation is actually very challenging, and you must, like Minu said, have practiced it many, many times before you are able to do it well in a complicated situation. Optic capture is another technique. In routine cases where you're doing a multi-piece IOL, just place the lens into the sulcus, then tip the optics into the rexus, then you can learn to do that optic capture, then dial the whole thing into the bag, and then in challenging situations that becomes also a practiced technique. Thank you.
Yes, Sunil, anything to say finally?
Yes, Matthew has enlightened, he has told whatever I wanted to say, actually, Matthew, Minu, Sudeep, everyone, and Chitra. But basically, yes, practice here, it's not easy to do in an already entered globe. It's a deflated balloon, so it's very difficult to do another incision, but you can practice. You can put in viscoelastic, and you can do it. And there is no need to shift your position. When you're making the incision, you're usually your upper temporal, you're to the right or to the left, whatever. And you stay in the same position. Because if you shift your position to a position that you're not accustomed to in a complicated situation, you're going to make things worse. So first is surgeon comfort, then is safety of the procedure. So don't make yourself more uncomfortable and go to a different position and operate. It's not possible. You are going to make a bigger mess. So you don't have to worry. Many people think that the incisions will connect. It will not, first. And even if it does, so big deal. It connects. You put a suture there. It's not a big deal. In all the cases that I have done right from the beginning, whenever I have converted, I have never put a suture. It didn't make. The other very important point is, when you get a problem is when you putting your viscoelastic, and I said this in Chaitanya last month, using your left hand before you bring out the handpiece and putting in a dispersive viscoelastic. If you think you are going to do it first time in a complicated case, it's going to be extremely difficult. So please practice in your normal cases. Just in your normal, any case, just leave the handpiece there. Then nothing has happened. Just practice putting viscoelastic with your left hand through the side port. Just practice that regularly. So that when the situation comes, it will be like second nature. The problem with when you get the complication, you're so worried that you pull out the handpiece. That's the natural reaction. So if you have practiced this again and again, you will not pull out that handpiece, and it will come to you naturally. These are the 2 points I wanted to highlight.
And finally, in case you have to hand over your case to your vitreoretina surgeon, it's most important that you suture your main wound and don't overhydrate the side ports. Just enough hydration to close it and then hand it over.
Other thing I wanted to say is, it's not a crime to leave the patient aphakic. Sometimes it's necessary to not put a lens because you create a bigger problem for the VR surgeon by doing that.
So I always go in with standby lenses, the same lens, one more, and then a 3-piece lens, and then your choice, iris claw, ACIOL, whatever. So every patient will have 4 lenses as standby, so no harm. You should not be stingy on keeping a library, or have your person, IOL person in, make friends with them, and so let them give you some stock and then let them take back or whatever, and have more lenses, because some lenses will come out without the haptic, some lenses will break, some lenses may get dropped, whatever. So you need always a backup, and leaving, it is not a sin, but it is very difficult to convince patients that I dropped your lens and there was no backup lens. No, what he is telling is not to create a problem in a complicated situation. But in any situation, if you have a 3-piece lens, if you don't have a 3-piece lens, then it's a problem. So have all these as backup, and putting a suture, everybody agrees it's not a sin. And it is required. When it is required, please do put in a suture, and you can take it out at any time. If the outcome is good, later on you can always tell that there is something sticking to your conjunctiva or skin, or which I will pull it off right now. They will say pull it off, no problem. So you can get away with suturing, but take it off early. Otherwise they will go to somewhere else, and somebody will see, and they stitch it. Hey, stitcho. No. So then that creates an unnecessary thing. But there are people who you come and ask, stitch it ittille adu edukkande ennu choikkum. So anganeyum choikkuna patient undu, but then still try to be open as much as possible, but the suture part and all, you can just handle it carefully. So with all this, we come to the end of this. Yes, Mohan sir.
It was really a master class, and learned a lot. Only 2 things I want to, one is already you mentioned, I think suturing is very important, because the incidence of endophthalmitis goes up by about 5 times if you don't suture, because there can be micro leaks, especially when you have vitreous loss. Second thing is, many people, anterior segment surgeons, okay, they get referrals because they use vitrectomy probes which are not being sterilized. It lies in the shelf for quite some time. They have not used it for quite some time, because occasionally only the PCR occurs. maybe 1 in 500 or 1 in 1,000 cases, they would have had PCR. At that time, they would have had the vitrectomy probe sterilized long time back, and the unsterilized vitrectomy probe, please understand, that is one of the most common causes of endophthalmitis after PCR. So I think this is a very important point everybody should take home. Make sure that your vitrectomy probe, plan A, B, C, Sunil Tangaraj was talking about it, plan A, B, C, make sure that your vitrectomy probes are sterilized at the appropriate moment every time.
I'll go further than that.
Yes.
I will tell, please make sure that your theatre and yourselves know the connection of how to connect the vitrectomy.
Yes, yes.
Know that your vitrectomy is working. Don't ask them to put it on and say, oh, it's not working.
And normally you make a big noise and the patient
Yeah.
also knows what exactly is happening.
Very-
And if you are not giving intracameral antibiotic on a regular basis, when you have a PCR, please do it.
Yes.
Okay, please do it. Very important.
When the two chambers are, then you can even give double. 0.1, you can even give 2 if the chambers are connected. Thank you very much for the inputs, Dr. Mohan Rajan. And all these sterilized ones should be kept in a separate packet. Separate packet. Forceps, all these viscode and all those things should be separate. Immediately it should be available. Yes, madam. So we will come to the end of it. We have 2 external faculty. Now we have to give you mementos. Madam, late. Please come. Please come. We will hand over the memento first to Dr. Chitra.